Shall I? Hello everyone, hope you're all doing good. This is Dr. Agalya Velo, your organic faculty. And now I'm going to take you into the intricate world of amenorrhea. I know this is a difficult topic, but but now I have simplified it according to me. Let's start the topic. Okay. So in this session, we are going to discuss what is amenorrhea, what are the different types of amenorrhea, namely primary amenorrhea, secondary amenorrhea, what are the causes causing primary amenorrhea, secondary amenorrhea, how the clinical presentation will be, what are the different investigations you have to offer them, what will be the differential diagnosis of each condition, and how we are going to manage amenorrhea. Okay. Now, before starting this, I want to discuss about the pubertal changes in female. Okay, so pubertal changes in female starts with the growth spurt first, which will be followed by breast budding and pubic hair development. Okay, so the terms which are used to define these conditions are telarchy, pubarchy and menarchy. So telarchy is nothing but the onset of breast development, which usually happens around 8 years, and then pubarchy, which is the onset of pubic hair development, which happens around 10 years, and then comes the menarche, which is the onset of first menstruation, which will be happening roughly between 12 to 13 years. Okay, so roughly if we take, menses usually occurs within 1 year of peak growth velocity, and within 2 years of pubic hair growth and breast development, and finally it's the bone age, which will be approximately around 13 years at puberty. Okay, so these are the physiological changes you have to know that is happening during puberty, right? Now let's define what is amenorrhea first. What is amenorrhea? Amenorrhea is the absence of menses. Okay, and amenorrhea can be due to physiological as well as pathological causes, but if you see, the overall pathological prevalence of amenorrhea is around 3 to 4%. Clear? Now we can define amenorrhea into two types. First one is primary amenorrhea, and the second type is secondary amenorrhea. Okay, now let's define both these terms. Okay, so what is primary amenorrhea? The primary amenorrhea is the absence of menses by 14 years of age when there are no secondary sexual characters. Okay, no secondary sexual characters, and then Otherwise, it can also be defined as absence of menses by 16 years of age when there is secondary sexual characters. Clear? Now, some books define this cutoff as 13 years when there is no secondary sexual characters and 15 years when there is sexual characters. So, ideally, if there is a case of primary amenorrhea, we have to start investigating them between 13 years and 15 years respectively in both these cases. Clear? Right. Now, let's also see the definition of secondary amenorrhea. So, secondary amenorrhea is nothing but the absence of menstruation in a female who was previously menstruating. Okay. So, she was previously menstruating. Clear? Now, not all the women has regular cycles. Yes, some of the women are having irregular cycles as well. So, according to that, if the women had regular cycles or irregular cycles, we can keep a cutoff for secondary amenorrhea in regularly menstruating women as 6 months and in irregularly menstruating women for a period of 3 cycles of her menstrual cycle. Okay, because in irregular cycles we don't have a particular days of menstruation. Okay, so she will be considered for 3 cycles. Okay, so if she doesn't have cycles for 3 cycles of her duration means then it will be considered as secondary amenorrhea in her. Clear? Right. Now, let's do some physiology now. I want to do the physiology of menstruation. Okay, physiology of menstrual regulation. Okay, so which is the highest center operating here? Yes, it is the hypothalamus. So it starts with the hypothalamus, which will be giving signals to the anterior pituitary, which will be acting upon the ovary, and finally it is going to be the uterus. Okay, so what is produced from hypothalamus? It is, yes, it is gonadotropin releasing hormones. And when it acts on anterior pituitary, you are going to get the gonadotropins, which are nothing but the follicle stimulating hormone and the luteinizing hormone, which is going to act on the ovary to produce the estrogen and progesterone, and that will be acting on the uterus. Okay, and finally from the uterus, what is going to happen? Yes, menses is going to happen, which is nothing but the shedding of the endometrium of the uterus. Yes, and for this menses to come out, what is another important factor we need? Yes, you need a patent outflow tract. Okay, so all these things should be functioning normally. Okay, so it is the hypothalamus followed by the anterior pituitary, then the ovary, uterus, as well as the patent outflow tract. Not only this, a number of other factors also determine the physiology of regular ovulation, which will include your karyotyping of the female, then her thyroid function, adrenal function, her nutrition, and metabolism. Okay, so all these things should be functioning normally. Clear? Only then the menses will be normal, her cycles will be normal. Clear? Now, let's discuss about primary amenorrhea in detail first, then we'll be going to secondary amenorrhea. Clear? Right. So, primary amenorrhea. Already we saw the definition. Now, let's discuss about the causes of primary amenorrhea. Okay. So, causes of primary amenorrhea, I am dividing it into various compartments, okay, so that it will be easy for you. First, let us see the uterovaginal causes, okay. So, this will be constituting the anatomical or developmental defects, okay. So, these include your MRKH syndrome. So, MRKH syndrome is nothing but Mayer-Rokitansky Custer-Hauser syndrome. Clear? Then, there can be any cervical atresia or imperforate hymen or a transverse vaginal septum. Okay. So, these are some of the causes that is leading to primary amenorrhea, uterovaginal causes, okay, which will be causing the anatomical defects, okay. Now, the second set of cause, we'll discuss about the ovary. Ovarian causes are mostly due to chromosomal abnormalities, okay. So, it is mostly due to the chromosomal abnormalities. And chromosomal abnormalities means which is the most common one? What is ovary actually? Yes, it is a gonad of female, right? So, any dysgenesis in the ovary will be causing primary amenorrhea. Yes. So, what are the various types of gonadal dysgenesis we can have? Yes. We can have very good Turner syndrome. It is 45X0. It can be a mosaic Turner's as well, which is 45X0 or XY. Then Swyer syndrome, which is 46XY. And finally, it can be a pure gonadal dysgenesis as well. Okay. So, it can be a pure gonadal dysgenesis as well. Okay. Which is 46XX. Okay. And I want to add one more point here. Not only gonadal dysgenesis, in some patients, okay, if the PCOS is occurring in early age before the onset of her menarche also, then PCOS can be a cause of primary amenorrhea also. Okay, so PCOS can be added as a cause of primary amenorrhea as well if it sets early before menarche, right? Yes. Now, let's see the next compartment, that is pituitary. Okay, so in pituitary, if there is any tumor, infection, tumors like craniopharyngioma, okay, or if there is any infection, or if she has undergone any surgery, then if there is infarction or empty sella syndrome, or if she is a case of hyperprolactinemia, okay. So, all these cases can lead to primary amenorrhea, right? The next compartment is hypothalamus. Hypothalamus causes may include, most of the causes are idiopathic here. It may also include Kallmann syndrome or any tumor, okay. And we have seen some other compartments as well, right? So, if there is any abnormality in the thyroid, like if there is hypothyroidism, then that can be a cause of primary amenorrhea. Adrenals, if there is any tumor or congenital adrenal hyperplasia, and finally some receptor and enzyme defects. Okay, receptor and enzyme defects can also lead to primary amenorrhea. Examples of these defects include your 5-alpha reductase deficiency, and another one is androgen insensitivity syndrome. Okay, I'll explain you about this when we are coming to that particular area. Okay, right. Now, so this is one type of classification. We should classify primary amenorrhea into a clinical basis also. Okay, so that is also very important for coming to a particular diagnosis. Okay, so if you get a case of primary amenorrhea, you have to clinically see whether there is normal secondary sexual characters or there is absence of secondary sexual characters. Clear? So, if they have normal secondary sexual characters, then they will be mostly eugonadotropic, and some of the conditions that comes under this category include your Mullerian agenesis, androgen insensitivity syndrome, vaginal septum, imperforate hymen, and sometimes it can be a constitutional delay also. Okay, and when you get a case of primary amenorrhea where there is absence of secondary sexual characters, you have to check the FSH. Okay, FSH can be high or low. Clear? So the conditions in which FSH is high is named as, yes, very good, it is hypergonadotropic. Okay, the conditions in which FSH is low are named as hypogonadotropic. Okay, so what are the hypergonadotropic conditions that is leading to primary amenorrhea? So when gonadotropes will be secreted more, yes, gonadotropes has to act on the ovary, gonads, right? So when there is ovarian dysgenesis, obviously the gonadotropes will be secreted more, right? So it is secreted more in gonadal dysgenesis or otherwise ovarian failure. Clear? And the next one is hypogonadotropic hypogonadism that is leading to primary amenorrhea. So here we have a set of conditions which will include, it can be constitutional as well, hypogonadotropic. So gonadotropin releasing hormone and gonadotropes itself are not produced well. So that will include your Kallmann syndrome. It can come from stress, any tumors, then anxiety, then congenital adrenal hyperplasia, so on. Okay, so these are some of the list. This is how you clinically classify primary amenorrhea. Clear? Right. Now, let's look how we are going to examine the patient. What are the important points you have to see while examining a case of amenorrhea? So, examination of a patient with amenorrhea should include Tanner staging. Okay, so Tanner staging, the staging that is done to assess the development of pubertal changes in a person. Okay, say it a male or a female. Okay, so for Tanner staging of a female, we have to assess breast, pubic hair, and then axillary hair. Clear? Followed by this, we have to go a parietal examination. Okay, to take the presence of, to examine the presence of any bulge. Okay, so in case of cryptomenorrhea, we'll be discussing it shortly. Okay, and then you have to go for the examination of the external genitalia, and last but not the least, you have to check in these females about if they have any inguinal hernia also. Okay, because in some cases these inguinal hernias are not actually the hernias but the undescended testes. Clear? So this is all about examination you have to do. Okay, anyhow, we'll be discussing the clinical features that each group of patient will be presenting in the following. Okay, so what are the investigations you will be offering to this people? So always, whether it is primary amenorrhea or secondary amenorrhea, you have to give them a pregnancy test. Okay, so this is the first to be executed in both primary as well as secondary amenorrhea. Okay, and remember, pregnancy is the most common cause of secondary amenorrhea. Okay, and the most common cause of primary amenorrhea is gonadal dysgenesis. Clear? And this will be followed by the anatomical defects. Okay, say MRKH syndrome and all. Clear? So it is always the pregnancy test you have to offer these patients, right? And the second one you have to check is the serum follicle stimulating hormone and luteinizing hormone. Okay, so the normal levels of these hormones are 5 to 20 international units per liter. Okay, and in some cases of secondary amenorrhea, say PCOS, and in some cases of in some case of primary PCOS is a cause of both primary as well as secondary amenorrhea. So in some cases like PCOS and Asherman syndrome, which is a cause of secondary amenorrhea, you will have normal gonadotropin levels also. Okay, but when it is high, say when the FSH is more than 20 international units per liter and LH is more than 40 international units per liter, then yes, it is going to be a hypergonadotropic hypogonadism, right? So these conditions can include your Turner syndrome as an example. Okay, then low levels of gonadotropins. Okay, when it is less than 5 international units per liter, it is hypogonadotropic hypogonadism, and example for this is functional hypothalamic amenorrhea. Okay, not only this, we have to offer them other investigations as well, which will include your thyroid stimulating hormone. Yes, when it is high, the reason is going to be your hypothyroidism, and when it is low, the cause is going to be hyperthyroidism. But yes, obviously hyperthyroidism is not a cause of amenorrhea. Okay, then prolactin. If the levels of prolactin are high, It can be due to pituitary adenoma, drugs, or again hypothyroidism as well. I will explain this again. Okay. Then you have to check for the testosterone as well, which is high in PCOS, congenital adrenal hyperplasia, Cushing syndrome, or any ovarian or adrenal neoplasm. Okay. And I want to tell you about one important investigation. Yes, it is going to be karyotyping. Okay, remember, karyotyping is one of the best investigation we can offer to the patients. Okay, but remember, this is not going to be the first investigation we should offer them. Okay, this is one of the best. Okay, so it is the best investigation to be offered in a case of primary amenorrhea. Okay, so once again, I will review the karyotyping here. Okay, for various conditions. In Turner syndrome, what it is going to be? Yes, it is 45x0. And if it is mosaic Turner syndrome, means this is going to be 45x0 bar xy. Then in your Swyer syndrome, it is 46xy. And in Kallmann syndrome, and whenever you have a uterovaginal agenesis, that is MRKH syndrome, your karyotyping will be 46XX. Clear? Right. We still have some investigations. Very important investigation is USG pelvis. This will show you whether the uterus is present or absent. Clear? Yes, uterus can be absent in MRKH syndrome. Okay, not only about the uterus, you can even study about the ovary as well. Okay, you can know about whether any PCOS is present in the ovary or any tumor is there. Okay, all these things you can study. And in some cases, you need some extensive investigations like MRI brain or pelvis. So MRI brain is needed when you suspect any pituitary adenoma like that, and MRI pelvis is needed when you suspect outflow tract obstruction. Okay. Finally, in some cases, hysteroscopy and diagnostic laparoscopy can also be done, which will be serving both as a diagnostic and treatment modality. Clear? Yes. Now, so to summarize, let's discuss how we are going to have a diagnostic approach in a case of primary amenorrhea. So first, you have to obtain the history and examination. Then you have to give them a urine pregnancy test and other hormonal test as well, like follicle stimulating hormone, luteinizing hormone, thyroid stimulating hormone, prolactin, USG pelvis, and any other test as required. Then if suppose the USG is positive, you have to first exclude ectopic, and if there is any thyroid abnormality, you are going to treat thyroid. And if there is hyperprolactinemia, you have to offer them MRI to exclude any adenoma, and you have to start them on dopaminergic drugs. Clear? And when you do USG pelvis, you have to see whether the uterus is present or not. Okay. Suppose if the uterus is present, then you have to consider the gonadotropins. Okay. So if your gonadotropins are low, both FSH and LH are low, then it can be due to delayed puberty or functional amenorrhea, right? And if the FSH and LH are normal and still there is amenorrhea, uterus is present, gonadotropins are normal, but bleeding is not happening, that is the menses is not happening because of outflow tract obstruction. Clear? Then uterus is present, FSH and LH are high. So that means Where the gonadotropes have to act, they have to act on the ovary. So there is a primary ovarian failure. Okay, so in that case, we have to consider Turner, and you have to rule out any Y containing karyotypes. Okay, I'll tell you the importance of this Y containing karyotypes later. Okay, then if suppose you have the uterus is present in the women, okay, and karyotype serum testosterone you're offering to that woman, karyotype says it is only a female karyotype, that is 46XX, then it is with normal testosterone levels, then you have to consider your MRKH syndrome. Clear? But the karyotypes comes as 46XY with the male pattern testosterone. The testosterone levels are just like a male pattern. Then it will be your androgen insensitivity syndrome. Clear? So this is how, in short, you will have a diagnostic approach to your primary amenorrhea cases. Clear? Now, let's discuss about each condition separately in primary amenorrhea. Clear? Right. Now, first I want to discuss the outflow tract obstruction. Outflow tract obstruction means we can have two main conditions. Okay. So, it is going to be your imperforate hymen or transverse vaginal septum. Okay. So, imagine we have a uterus over here like this. Okay. And somewhere, okay, so there is, this is the cervix, okay, this is the cervix, and this is the vagina. Okay, so here I have a septum. So when the menstrual bleeding is happened, it has to come out obviously, right? Whenever there is a septum here, it is not going to let the blood out, right? As well as in the case of imperforate hymen also. Okay, when the hymen is imperforated, how the menstrual blood can come outside? So it is not going to come outside, and definitely it is going to collect inside the uterus right from your vagina. Clear? Okay. So what is the inference we got here? Whenever there is an outflow tract obstruction, menstrual blood is not going to come out. It is going to stay inside. So it leads to the collection of blood in the genital tract. Okay. And collection can happen right from the vagina or uterus, and it can even spread to the tubes. Okay. So the terminologies we offer here to represent these different conditions include, when it is collected in vagina, we call it as hematocolpos. When it is collected in the uterus, we call it as hematometra. And when it comes and collects in the tubes, okay, it will be known as hematosalpinx. Okay. And remember, it will be collecting only in this direction. Okay, it will be the vagina first which is filling, because this comes and settles down here, then followed by the uterus, then it will be spreading out to the tubes as well. Clear? Yes, right. Now, what happens when such thing is happening? How will be the patient presenting to you? Yes, she will be presenting with cyclical abdominal pain. Okay, this will be cyclical at the starting, but as it progresses, it may even become persistent. Okay, so it may even become persistent. Okay, imagine when the uterus is getting completely occluded, completely filled with the menstrual blood, it is going to distend, and this distension is going to affect on the adjacent organs also, especially the bladder is going to get affected. So what happens? She may also present with urinary retention. Okay, so urinary retention can also happen. Okay, and remember, in these cases, there can be anomalies of urinary tract as well as kidneys. Okay, so you have to rule out these conditions also. Okay, and one more thing I have to mention is that, see, when this is happening, I told you the blood is going to collect in this direction, okay, in a retrograde manner. So what is going to happen? Obviously, what is here? Yes, the ovaries are there, and there is a retrograde flow of menstruation to the ovaries also, right? But anywhere it can lead to endometriosis, okay, because there is a prolonged retrograde menstruation as well. Okay, right. Now, what will you have on examination, okay, in these patients? While examining these patients, you will see normal secondary sexual characters. Okay, they will have normal secondary sexual characters, and when you do a per abdomen examination, you will have a palpable uterus because there is hematometra, right? Then local examination will show a enlarged bluish tinged tense bulging membrane. Okay, in case of, this is in case of imperforate hymen. Clear? And then in some cases, the vaginal opening can itself be absent. Okay, so that is a case of vaginal agenesis. Okay, and finally, we can have transverse vaginal septum as well. Clear? Yes. Now, the transverse vaginal septum, we take the uterus, can be present anywhere. Okay, like it can be a high vaginal septum, or it can be a mid vaginal septum, or it can be a low vaginal septum. Okay, so this is a high septum, this is a mid septum, and this is a low septum. High septum is one of the most common cause of transverse vaginal septum. Okay, most common presentation. Okay, so what you will do in this case for management? Yes, for management, what you will do in a case of, say, cryptomenorrhea? Okay, like it is happening due to imperforate hymen. What you will do? So this is how it will be. Okay, so this is how it will be. Here the bluish tinge is not visible, but even then I hope you will be able to see the bulge over here, right? Yes, you are able to see the bulge over here. Okay, so this is how cryptomenorrhea or the imperfect hymen will be there on local examination. So for these patients, we'll be treating them with a cruciate incision. A cruciate incision, cruciate means across, okay? Across incision will be given, and so that whatever the collection of blood is there inside the uterus or vagina will be let out like this. Okay, so I hope you're able to see. We give a cruciate incision and we'll let out the collected blood. Okay, so this is all about the treatment of cryptomenorrhea. Very easy, right? Right. But here only this is the procedure. Okay, hormonal action and everything is normal for this patient, so no need to supplement with any other hormonals. Okay, right. And for vaginal agenesis, okay, suppose if she has vaginal agenesis, then we will offer her a procedure called vaginoplasty. Okay, so what is vaginoplasty? Vaginoplasty is the creation of new vagina. Okay, neovagina, that is new vaginal pathway. Okay, so that is vaginoplasty. Clear? And in cases of vaginal septum, we'll be going for a simple, yes, we'll be going for a septal resection. That's it, done. Clear? Yes. So this is all about your outflow tract obstruction. Okay, 3 conditions you have to know: vaginal agenesis, transverse vaginal septum, and cryptomenorrhea. Yes, that's it, right? Now, coming to the one of the interesting topic in primary amenorrhea, that is Mayer-Rokitansky-Kuster-Hauser syndrome. Okay, so this is a condition where there is complete Mullerian agenesis. Okay, so there is complete Mullerian agenesis. So what happens means, here the uterus, okay, cervix, as well as upper part of vagina, okay, so all of this are going to be absent. Okay, so your uterus, cervix, and upper part of vagina are going to be absent. Okay, because these are the structures that are going to develop from your Mullerian duct. Okay, your lower part of vagina is going to develop from the, yes, is going to develop from the sino-vaginal bulb. Okay, and the ovaries or the gonads, which are going to develop from the ridges, right? So these structures will be present in these women. Only the Mullerian duct is going for agenesis. Clear? Yes. So if you see in this woman, so this is how a normal woman will be having her internal genitalia. Okay, so a normal uterus. Okay, you have the uterus, you have everything, cervix or vagina, fallopian tubes, ovaries, everything. Okay, so this is normal. If you consider it in a Rokitansky syndrome, okay, so all these unshown parts are not present in this woman. Okay, there is absence of uterine tubes, fallopian uterus, fallopian tubes, as well as the vagina. Remember, the lower part of vagina is present. Okay, and there is also presence of ovaries. Fallopian tubes are absent, and in some cases you may even have distal part of the fallopian tube. Okay, clear? So this is about Mayer-Rokitansky-Kuster-Hauser syndrome. Okay, now, so apart from this, one more thing I want to mention, that is in some cases you may have a smaller knob of Mullerian tissue. Okay, Mullerian tissue can be present. Okay, a small knob, okay, can be present in these women, and this will go for cyclical changes. Okay, as it goes for cyclical changes, what is going to happen? Yes, there will be cyclical bleeding. Okay, when this endometrium is particularly active, and it can lead to cyclical abdominal pain. Remember, it is not the whole uterus, it is going to be only a small knob of Mullerian tissue, which is going to be vestigial only. Okay, but it is going to produce discomfort in the patient because it got some hormonal activity. Clear? So this is same. And what you have to know is, these women are karyotypically normal. Okay, so their karyotype is normal, that is 46XX, and they will be like a typical females. Okay, typical females. Okay, they are typical females actually. Okay, so typical females, and they have obviously, yeah, normal secondary sexual characters. Okay, and you have to understand one important point here, because the Mullerian duct is going to come with the development of the metanephric duct, which is going to give rise to your urogenital system. Okay, so that's why we call it as urogenital system. Okay, both your urinary and genital system are going to develop together. So whenever there is a defect in the Mullerian system, it is going to affect the metanephric duct also, right? So it can be associated with renal abnormalities or skeletal abnormalities as well. Okay, so renal abnormalities are seen in 15 to 40% of the patients with MRKH syndrome, and skeletal abnormalities are seen in 12% of the patients with MRKH syndrome. Clear? Yes. So, when you examine this woman, okay, they will be a typical female, as I have told. Their secondary characters are well developed, breast is well developed. But when you do a local examination, yes, you will find the vagina to be blind, okay, because only the lower part of the vagina has developed. Okay, the upper part has completely undergone agenesis. Okay, so it's not going to be an opening, it's going to be just a vaginal pouch, a blind vaginal pouch. Clear? Right. So, what are the investigations you have to offer in this women? So, investigations you have to offer include, yes, first one you have to offer USG. When you offer ultrasonogram, you can check if the uterus is present or absent, as well as if any renal abnormality is present, that can also be seen via USG, right? And in some cases, you can even offer MRI pelvis, especially in the cases those who are presenting with cyclical abdominal pain, because in them, yes, the Mullerian remnant can be detected via MRI pelvis. Clear? And in some, what are the other investigations you can offer? Means you can offer karyotyping. This karyotyping is definitely going to be 46XX, and then you can check testosterone in these females, which is going to be normal levels, normal female levels. Okay. Then when you do a laparoscopy, okay, you will be able to find the ovaries are normal, and as I said, in some cases the distal end of the fallopian tubes can also be seen, and some cases the Mullerian remnant or Mullerian tube as such itself can be seen. Clear? Yes. Now, other investigations you can offer will include your intravenous pyelography, okay, for urinary tract abnormalities, and then it's going to be your X-ray for your skeletal abnormalities. Okay, so these are the various investigations you will offer for a woman with MRKH syndrome. Okay, USG, MRI pelvis, karyotyping, testosterone levels, laparoscopy, IVF, and X-ray. Clear? Now, let us see how we are going to manage this patient. Okay, so management part is very important. So, management, remember, in this woman, uterus is absent. So, even if you give hormonals, will menstruation will be happening? Yes? No, it is not going to happen because the endometrium is not going to be there, right? In most of the cases, remember, forget about the knob of Mullerian tissue that is present. Okay, in most of the cases, there is no uterus, menstruation is not going to happen, so there is no use in giving them hormonals. Okay, so you have to help the patient only by restoring the coital function, okay, to help her in her married life. Okay, so for that we can do vaginoplasty, okay, and you can offer her other reproductive options, okay, like she can go for surrogacy, and nowadays uterine transplantation can also be done, okay, and this can be followed by assisted IVF or embryo transfer. Okay, so these are the reproductive options for her. Clear? Yes. Now, let us talk about one of the most confusing syndrome, what I say. I see many students struggling with this syndrome. So, it is going to be androgen insensitivity syndrome. Okay. So, I am going to discuss in detail about this androgen insensitivity syndrome. Okay. So, androgen insensitivity syndrome, the other names are testicular feminization syndrome, or it is also known as male pseudo-hermaphroditism. Okay, so it is a male pseudo-hermaphroditism. Anyhow, we are not using this terminology now. It is either androgen, it is mostly androgen insensitivity syndrome. Sometimes it is also referred to as testicular feminization syndrome. Clear? Right. Now, so remember the karyotype here is going to be of a male. Okay, it is 46XY. Very, very important. Clear? Then, if you ask me how the pathology is happening, means there are androgens. Okay, say testosterone and dihydrotestosterone. Okay, so these are the androgens. And we know how dihydrotestosterone is produced. Yes, testosterone is acted upon by the enzyme 5-alpha reductase to get converted into the hormone dihydrotestosterone. And for complete differentiation of external genitalia in a male, we need both these hormones, testosterone and dihydrotestosterone, as well as the enzyme 5-alpha reductase, as well as the receptor. Okay, finally, the receptor on which these hormones are going to act should also be functioning. Yes, so all these things should be in a properly working fashion so that your normal male external genitalia will be seen, right? If there is abnormality in any one of the level, then it is not going to happen. Especially in androgen insensitivity syndrome, there is a receptor defect or there is a 5-alpha reductase deficiency. Clear? Right. So, what happens? There is androgen receptor defect, or there can be a 5-alpha reductase deficiency. Okay, so what happens? There is less testosterone binding. Okay, and there is less virilization as well. Clear? Now, but in these persons, we have estrogen, okay, that will be derived from the peripheral conversion. Yes, what is the enzyme acting here for the conversion of androgens to estrogen? Yes, it is aromatase, right? Okay, anyhow, we can derive and estrogens from androgen, that I want to make it. Okay, so because the estrogens are derived, estrogen receptors are going to be active. What is going to happen? Yes, the breast development is going to happen. Estrogen is responsible for the breast development. Okay, so this is one point. And another point I want you to tell is there is AMH. Okay, so AMH will be absent. Okay, sorry, AMH will be present. Anti-Mullerian hormone will be present, and this will be preventing the development of internal Mullerian structures. Okay, all the female internal organs are not going to be present as well. Clear? Okay, so this is all about androgen insensitivity syndrome. But I'll make it clear, don't worry. So we are going to see some of the types of androgen insensitivity syndrome. Okay, so in that we have complete androgen insensitivity syndrome, then incomplete or partial androgen insensitivity syndrome, and the condition that is happening due to 5-alpha reductase deficiency. Okay, yes. Now, let's see the differentiating features between all the three conditions. Okay. So, by the end of this table, you will be able to understand androgen insensitivity syndrome in detail. Okay. So, if you take, let's come with from inheritance. Okay. So, if we start with the inheritance, complete androgen insensitivity syndrome and partial androgen insensitivity syndrome are going to be X-linked recessive conditions. Okay. Whereas 5-alpha reductase deficiency is going to be an autosomal recessive condition. Clear? And then if we see the defect, okay, we know very well the defect in complete androgen insensitivity and partial androgen insensitivity is in the receptor, right? Or receptor especially, there can be either mutations or inactivation of the receptor. Okay. And then 5-alpha reductase deficiency means the testosterone to dihydrotestosterone conversion is not going to happen. Clear? And then we have, let's see how will be the feature of external genitalia. External genitalia in complete androgen insensitivity syndrome is going to be like a female, whereas in partial androgen insensitivity syndrome, it is going to be more ambiguous genitalia, and in 5-alpha reductase deficiency, it can be ambiguous genitalia, or here it can look more like a female also. Clear? Yes. And the next point is about the internal genitalia. How will be the internal genitalia? Internal genitalia, see, remember here internal genitalia and gonads in all these three conditions, whatever it is, they are coming under the classification of androgen insensitivity syndrome. So, definitely the internal genitalia is going to be that of a male and the gonads are going to be testes. Obviously, yes. So, internal genitalia is going to represent like a male and the gonads are going to be testes in all these conditions. Clear? Yes. And the next one, you have to know how they will be presenting. Okay. So, presentation, mostly complete androgen insensitivity syndrome people who are having this condition will be presenting at puberty. Okay. They will be presenting with primary amenorrhea with or without hernial mass. Okay. And in partial androgen insensitivity syndrome, they will be mostly presenting at infancy, and in these patients, there can be hypospadias or cryptorchidism and all. Okay. And 5-alpha reductase deficiency is also presented at infancy, and here they may have a little hypospadias, okay, little hypospadias, and then they can have a blind vaginal pouch or a bifid scrotum and all. Okay. Anyhow, the presentation you have to remember, complete androgen insensitivity syndrome is going to present to you only at puberty. That's why it is the most common cause of primary amenorrhea to present it to you among the group of androgen insensitivity syndromes. Clear? Whereas the partial androgen insufficiency and insensitivity and 5-alpha reductase deficiency are going to present earlier in the infancy itself. Clear? Right. Now, one more point. So, how will be the phenotype of these patients in complete androgen insensitivity syndrome? Okay. In complete androgen insensitivity syndrome, the phenotype will be like a typical female. They will have developed breast also. Okay. Whereas in partial androgen insensitivity syndrome, they can have a phenotype like partial masculine and partly developed breast. Okay. So, that will be confused with gynecomastia. Okay. In 5-alpha reductase deficiency, mostly they will have a masculine features. Okay. So, this is all about the various types of androgen insensitivity syndrome. By this end of this table presentation, I hope you have understood what is androgen insensitivity syndrome and what are the causes, right? Yes. Now, so let me tell you about the treatment also. See here in complete androgen insensitivity syndrome, since they are going to have a female phenotype, you have to rear them as females only. Okay, so at puberty, okay, you have to supplement them with hormones. Okay, and if there is, as I said, if there is inguinal hernias or gonads are present as a cryptorchidism condition, then you have to offer them gonadectomy. Okay, and in both these cases, okay, since it is of ambiguous genitalia, this should be decided earlier because you have to diagnose them at the infancy itself. Okay, so because of that, you have to decide them whether to rear them as a male or a female. Okay, and if you plan to rear them as a female, then obviously you will be giving these options to these people also. Clear? Right. So this is all about androgen insensitivity syndrome, but I hope we should right now finish this thing also, because there shouldn't be any confusion after this. Okay, so we are going to differentiate between the two conditions we have discussed now, right now here. Okay, it is going to be done. Okay, now let us see the breast development in androgen insensitivity syndrome. In androgen insensitivity syndrome, what I told, the breast is well developed. Yes. In Mayer-Rokitansky-Kuster-Hasa syndrome also, the breast is going to be well developed, right? The second condition you have to see is about the pubic and axillary hair, the testosterone function, right? So, how will be the testosterone function in androgen insensitivity syndrome? It's not going to act, yes. So, the hairs are going to be either absent or it is going to be scanty. Accepted? Yes. Whereas in MRKH, they will have a normal pubic and axillary hair growth. Clear? And the next feature is about the vagina. Remember, both in AIS, that is complete androgen insensitivity syndrome, and an MRKH, the vagina is going to be blind. Okay, and then the uterus is also going to be absent in both the things. I already told you, because in androgen insensitivity syndrome, there is anti-Mullerian hormone. Okay, then gonads are going to be testis in case of androgen insensitivity syndrome, whereas in case of MRKH, it is going to be ovary. Then we have to see the testosterone levels. Okay, testosterone levels are going to be within the normal male range in androgen insensitivity syndrome, whereas in MRKH, it is going to be in the normal female range. Clear? Right. And the next one is your karyotyping. Karyotyping is 46XY in case of androgen insensitivity syndrome, and in MRKH, it is going to be 46XX, right? And finally, yes, you can expect a X-linked recessive pattern of inheritance in case of androgen insensitivity syndrome, whereas MRKH doesn't show any kind of inheritance like that. Clear? Okay, I hope you have understood this differentiation. This is very important whenever you are given a clinical scenario or clinical presentation of a primary amenorrhea. The most of the chaos will be happening between these two syndromes. Clear? Right. Now, let's discuss about the gonadal dysgenesis condition. That I'm going to discuss first about Swyer syndrome. Okay, so Swyer syndrome, the karyotype here is going to be, yes, 46XY. The phenotype is going to be that of a female. Okay. Here in Swyer syndrome, what happens means you have dysgenetic gonads. Okay. Dysgenetic gonads, it does not produce androgen or anti-Mullerian hormone as well. Clear? Right. Now, let's see how will be the clinical presentation of these patients. Okay. If you take a person with Swyer syndrome, he will be or having a normal stature. Okay. They will have normal pubic hair development. Then the external and internal genitalia is going to be that of a female. Okay, normal, external and internal genitalia just like a female. Okay, but the breast is poorly developed or absent, and the other Mullerian structures, say uterus, tubes, cervix and vagina, are going to be normal. Clear? So that's why I already told you the internal genitalia is going to be a normal female type. Clear? Right. So only thing is the breast is poorly developed, okay, or absent. That is very important in Swyer syndrome. Clear? Right. So if you ask me, what are the investigations you will offer for this type of patients when they present with amenorrhea? Yes, investigations you will offer will include your LH and FSH, definitely gonadotropins we are going to check, right? So it is going to be dysgenetic gonads. So yes, it is going to be increased, and then USG is going to show the uterus, fallopian tubes or present, right? Yes, present. And then the karyotype is going to be like a normal male, 46 XY it is, right? Okay, so that's all. Okay, so this is all about Swyer syndrome. Only thing you have to remember is the karyotype is going to be 46XY and breast development is not going to be there, or it is poorly developed. Okay, so that is the only point you have here. Other features you can keep it just like a normal female. Clear? Yes. Now let's see how we'll manage this condition. So management, you can give them estrogen for breast development, then cyclical estrogen and progesterone can be given to obtain sexual maturation and also menstruation. And in these patients, yes, pregnancy is possible, but they have to go for procedures like IVF or ET, that is embryo transfer. Okay, and whenever you have a Y chromosome, you have to search for the testis, because a testis present in these type of persons are going to be getting converted into a, it is going to produce more malignancy conditions. Okay, so you have to offer them gonadectomy. Okay, because there is a risk of germ cell tumor up to 30% cases. It is seen in up to 30% cases. So definitely whenever you see a Y chromosome in these type of patients, definitely you have to offer them a gonadectomy. Clear? Right. Now, again, I want to make another differentiating feature. Yes. So it is between your CAIS and Swyers. Okay. So let's discuss now. So in complete androgen insensitivity syndrome, how is the breast going to be? Yes. How is the breast going to be? It is well developed, right? But in case of Swyer syndrome, breast development is absent, or it is poor or absent. Clear? And the next one is about the hair, that is pubic as well as axillary hair. In CAS, you have pubic or axillary hair? No, right? So it is absent. Whereas in Swyer syndrome, it is present. Clear? And next condition is, next one is vagina. Vagina is going to be blind in a case of complete androgen insensitivity syndrome, whereas it is going to be normal in a case of Swyer syndrome. Okay? And then if we see the uterus, uterus is absent, okay, absent in CAS, that is complete androgen insensitivity syndrome, whereas it is present in a case of Swyer syndrome. Clear? Right? And the next one is gonads. If we take the gonads, yes, the gonad is testis in CAS, whereas in Swyer's it is only ovaries, but they are going to be pregonads or dysgenetic gonads. Okay? When we check for the testosterone levels, in CAS it is going to be like a normal male, whereas in Swyer's it is going to be like a normal female. Okay? And so if you take in complete androgen insensitivity syndrome, menstruation and pregnancy, okay, both are questionable. That is, it is not possible at all. Clear? Whereas in Swyer syndrome, menstruation can be brought about by giving hormonal therapy, right? And then pregnancy is also possible with donor site. Clear? Yes? I hope there is no confusion between CAS and Swyer syndrome also. Okay? In Swyer's, remember the 2 points I said to you. Okay? So one is breast is going to be absent. And you can have other normal female features, and you can offer them treatment for bringing about menstruation as well as for bringing about pregnancy by donor oocyte. Clear? Right. Now, let's discuss Turner's syndrome. Okay, so our favorite syndrome, right? Everywhere we read Turner's, we say Turner's. Okay, now this is one of the most common syndrome. Okay, and we are also familiar with the syndrome, right? It is the most common syndrome. Say this constitutes about 50 to 60% of gonadal dysgenesis. Okay, then what is the karyotype? Yes, karyotype is 45X0. Okay, suppose if you have a mosaic Turner's, it is going to be 45X0 by 46XX. Okay, and mosaic Turner is found in 1/4 of the cases of Turner syndrome. Clear? Right. And if we see the overall incidence of Turner syndrome, it is very frequently seen. It is seen in 1 in 2,500 women. Clear? Yes? Right. Now, let us see the clinical presentation. So, most of them will be having short stature, okay, because in these people, there is a mutation in CHOX gene. Okay. Then, number 2, they have absent breast development. Number 3, they will only have a prepubertal type of external genitalia. Then they will mostly present as a case of primary amenorrhea. Okay, and what is the important other feature we know till now? Leave the other features of Turner syndrome. What is the other thing I told you? It is going to be gonadal dysgenesis. That means streak ovaries. Okay, so streak ovaries. So there is accelerated atresia in the ovaries as well. Okay, so what is going to happen is, because of this, some of the women, okay, they not only present with primary amenorrhea, some may even present as a case of premature ovarian failure or premature ovarian insufficiency. Clear? So this point should be understood. Okay, however, their IQ is going to be normal. Okay, and they have a high risk of accelerated death at a young age due to cardiovascular problems. We'll see it in a minute, but before that, I just wanted to show the features of Turner syndrome. Okay, so yeah, this is a Turner. Okay, so first one is going to be a short stature woman with low hairline, a shield-shaped thorax, widely placed nipples. There is short metacarpal, fourth metacarpal especially. Then there are small fingernails, okay, brown spots, that is, so many nevi are going to be present. There is characteristic facial features will be there, okay, a fold of skin will be there, construction of the aorta, poor breast development, elbow deformity, that is cubitus valgus, then rudimentary ovaries, that is streak ovaries, which is the underdeveloped gonadal structures, and there is no menstruation. Clear? So she is a Turner. Now, I want to discuss about the associated complications we can have in a Turner. Okay, so associated complications. Okay, I told you the death is going to be due to the CVS disorder, and cardiovascular disorders can include mitral valve prolapse, coarctation of aorta, okay, or bicuspid aortic valve, then aortic aneurysm or aortic dissection. Clear? And we can also have some renal abnormalities. Okay, renal abnormalities like horseshoe shaped kidney or a single pelvic kidney can also be seen in this women. Okay, and other associated comorbidities in this patient can include type 1 diabetes mellitus, systemic hypertension. Okay, there can be autoimmune conditions as well. Okay, autoimmune thyroiditis or immune hepatitis. Okay, so this is also possible. Clear? Right. Now, I told you it is 45x0. Okay, so what is happening in these people? One X chromosome is absent, right? So one X chromosome is absent. So what is going to happen? The ovaries undergo atresia, okay, and they form streak ovaries and there is no ovulation. Okay, so no hormones are produced by the ovaries. Okay, so there is no estrogen and progesterone. Okay, that means what is going to happen? FSH and LH levels are going to be more. It is going to act on the streak gonads to produce estrogen and progesterone, but the gonads are already damaged, right? They are not going to be responsive. So it is a hypergonadotropic condition. Okay, And if you see the female external genitalia, it is going to be normal. Okay, female external genitalia is going to be normal in these people. Okay, and this three gonads can be found out during your ultrasound examination or laparoscopy examination. Clear? Right. Now, let's discuss about the management of these patients. Okay, you have to give them estrogen for breast development, then cyclical estrogen and progesterone should be supplemented for their menstrual function, and then yes, pregnancy is possible in these people also, just like Swyer syndrome. Pregnancy can be by donor oocyte. And remember, you have to perform a cytogenetic analysis. Okay, and whenever you find Y chromosome presence, okay, if Y chromosome is present, then you have to offer them gonadectomy because there is a risk of malignancy. Clear? Right. Now, let's discuss one final syndrome in primary amenorrhea, which is Kallmann syndrome. Okay, so Kallmann syndrome is also a condition of hypogonadotropic. Okay, remember the problem is starting in the hypothalamus itself. So it is going to be a hypogonadotrophic hypogonadism. Okay, and the karyotyping in these patients is 46XX. Okay, Kallmann is 46XX. They are females only. Okay, and then how will be the gonads? I told you karyotyping is 46XX. So the gonads are going to be, yes, obviously it is going to be the ovaries. Okay, so what do you think the pathology in Kallmann syndrome? Yes, there is failure of migration of, yes, GnRH neurons. Okay, so what is going to happen is there is failure of migration of GnRH neurons from where? Yes, from the olfactory epithelium, from the olfactory epithelium to the hypothalamus. Okay, so what is going to happen? GnRH is going to be absent. When GnRH is absent, obviously the gonadotropins are absent, that is FSH and LH are going to be absent, and the estrogen is also going to be absent. Okay, because the absence of estrogen, yes, breast development is also not going to be there. Okay, so breast development is also absent, but remember the androgen levels are decreased. Okay, they are decreased to a very minimal level. Okay, so they are decreased to very low level only. Okay, so sometimes you can find a scanty axillary and pubic hair in these people. Okay, clear? And if you see the other clinical features of Kallmann syndrome, their height is going to be normal. Okay, external genitalia is going to be like that of a female. Okay, and then internal genitalia is going to be hypoplastic. And remember, a Kallmann syndrome can be inherited as a X-linked or autosomal dominant or autosomal recessive condition. Clear? Yes. And what are the other specific features of Kallmann syndrome you can have? Already I told you, yes, primary amenorrhea is going to be there. We are discussing this under primary amenorrhea then. Yes. Olfactory epithelium. Neurons are not going, right? There is no migration of that. So, yes, anosmia. Anosmia is going to be there. Okay. And they can also present with infertility, and another important point, they can present with midline facial defects. Okay, midline facial defects like cleft palate or cleft lip as well. Okay, clear? So this is all about Kallmann syndrome and how you are going to manage these patients. So management, you have to give them cyclical estrogen and progesterone to provide menstruation, and then you have to do ovulation, induction as well. Clear? So yes, with this we are finishing primary amenorrhea, right? Let's go into the discussion of secondary amenorrhea now, right? Yes. So secondary amenorrhea, already we have seen the definition, right? So I'll just recollect it here. When the amenorrhea is in a regularly menstruating woman is present for 6 months, and in a irregularly menstruating woman, if there is a amenorrhea for a period of 3 cycles of her duration, then it is going to be secondary amenorrhea. And also we have seen what is the most important cause of secondary amenorrhea. Yes, it is going to be pregnancy, right? Why there is amenorrhea in pregnancy? Because of the increased progesterone levels. Yes, because of the increased progesterone levels, right? Now, let's discuss about the causes of secondary amenorrhea. First is, we can have physiological causes. Okay, physiological causes will include lactation, pregnancy, and then menopause. Clear? And second one, there can be problems at the level of hypothalamus, which will include trauma or any other infectious conditions like tuberculosis or sarcoidosis. Clear? Right. And pituitary causes may include hyperprolactinemia, Sheehan's syndrome, and then pituitary adenoma as well. Okay. Then ovaries. In ovaries, already I told you a condition. Yes, it is going to be polycystic ovarian syndrome. Okay. Then there can be a condition called resistant ovarian syndrome or Sertoli Leydig cell tumor, or it can be due to radiotherapy or chemotherapy as well. Okay, it can be due to radiotherapy or chemotherapy as well. Okay, and in the uterus, you can have a condition called Asherman syndrome. Okay, Asherman syndrome, or even due to tuberculosis, when the uterus are affected by tuberculosis. And then finally, the other conditions you have to consider include your thyroid dysfunction, okay? Then your Cushing's, Addison's disease, and any chronic debilitating disease, and your post-pill amenorrhea as well. Clear? Right. Now, here I would like to discuss some of the important causes of secondary amenorrhea, and I'm going to start with hyperprolactinemia. Yes. So let's discuss in detail about hyperprolactinemia. Okay. So first, let us discuss what is prolactin. What do you know about prolactin? Yes, prolactin is secreted by, yes, it is secreted by the anterior pituitary, but which cells of anterior pituitary? It is going to be the lactotropes. Yes, lactotropes. And remember, this is a single chain polypeptide hormone. Okay, single chain polypeptide hormone. Okay, it has intramolecular disulfide bonds as well. Okay, and if we take prolactin, we have various types of prolactin. Okay, so it can be present as a monomer, okay, or di or trimer, and finally there can be a big structure that will be named as macroprolactin. Okay, so if we see the size, okay, average molecular weight of these structures, a monomer prolactin can be anywhere between 23 kilodaltons, and a di or a trimer can be having higher molecular weight, say 50 to 60 kilodaltons, and macroprolactin can have more than 100 kilodaltons. Okay, so this is the larger variety. Okay, and monomer is going to be the most common type of prolactin form, that is constituting 80 to 90%. Okay, as well as a monomer is going to be the most biologically active form of prolactin as well. Okay, and you have to know the normal serum prolactin level. Okay, normal serum prolactin level. Yes, normal serum prolactin level is going to be less than 10 to 20 nanogram per milliliter, and the T half of this hormone is going to be 50 minutes. Okay, usually the hormone is going to rise nocturnally after sleep. Okay, and it can peak up to the normal range is less than 20. During sleep, while you're sleeping in the night time, it can rise up to 30 nanogram per milliliter, and it may be even double than its original value when you measure it between 4 to 6 a.m. Okay, so ideally you have to measure the serum prolactin level in the morning. Okay, when you are having this prolactin nadir. Prolactin nadir means there is a sudden rise, right, between this 4 to 6 a.m. So this, during this period of prolactin nadir only, you have to measure this. Okay, and remember, you should not offer the patient any breast examination before doing this prolactin, as well as you should ask the patient to avoid any stress also. Okay, suppose if you see there is a mild elevation of prolactin during this time, you have to remeasure it again. Okay, anytime during the day. Fine. Now let's see how prolactinemia is going to cause menstrual problems, that is amenorrhea. Okay, so what are the effects of hyperprolactinemia? Okay, so when there is mild hyperprolactinemia, say when there is mild hyperprolactinemia, let's keep the range as 20 to 50 nanogram per milliliter. This is going to cause a short luteal phase. Clear? And when you have a moderate level of hyperprolactinemia, say the levels are going to rise between 50 to 100 nanogram per milliliter, then this is going to cause oligomenorrhea or amenorrhea. Okay, this is going to cause oligomenorrhea or amenorrhea. And finally, in the severe type, okay, where the prolactin levels are more than 100 nanogram per milliliter, okay, they will present with a typical state of hypogonadism and low estrogen levels. Clear? Yes. So this is how hyperprolactinemia, as the prolactin levels are increasing from its normal range, this is how the menstrual cycle abnormalities are seen. Clear? First there is a short luteal phase followed by oligomenorrhea or amenorrhea, and finally it goes for a complete hypogonadism where the estrogen levels are also going to reduce. Right? Yes. Now let's also discuss about the tumor in this one, pituitary, that is macroadenoma or microadenoma. Okay, so it is going to be macroadenoma when the tumor size is going to be more than 10 millimeter, okay, or more, and it is going to extend beyond the pituitary fossa. Okay, and the next one is microadenoma. Here the size of the tumor is going to be less than, or it is going to be less than, okay, it is going to be less than 10 millimeter, and it does not distort or it does not extend beyond the pituitary fossa. This is not going to happen here. Clear? Fine. Now in some cases microadenoma can progress to macroadenoma. Okay, and remember, the levels of prolactin in microadenoma rarely exceeds, never exceeds more than 200 nanogram per milliliter. But in macroadenoma, the levels are going to be more than 200 nanogram per milliliter. Clear? Going to be more than 200 nanogram per milliliter. Clear? So this understanding should be there. And that's why we need a MRI. Okay, because there is a poor correlation between the size of the tumor and the prolactin levels. We need a MRI for the final confirmation for the presence of tumor and whether it is a micro or macroadenoma when there is a disparity between the levels of prolactin and the size of the tumor expected. Clear? Yes. Now, another important point I have to discuss in hyperprolactinemia is what are the causes of hyperprolactinemia? Yes, we have to discuss that, right? So let's see the causes of hyperprolactinemia. Okay, so there are both physiological as well as pathological causes. Okay, you have both physiological as well as pathological causes. Physiological causes will include pregnancy, lactation, stress, or nipple stimulation. So that's why I told you, when you're going to measure prolactin levels, there should be no breast examination. Okay. And pathological causes of hyperprolactinemia will include, yes, obviously prolactinoma. That's what we have discussed, right? And it is going to cause 50 to 60% of the cases. Okay. Whereas we also have some drugs that can cause hyperprolactinemia. Okay. So these drugs can include your phenothiazines, haloperidol, metoclopramide, cimetidine, then may also include your methyl dopa, antipsychotic drugs as well. Okay, and remember, hypothyroidism can also present with hyperprolactinemia. Clear? So it is also hypogonadism. Have to keep it in mind. Right? Now, I want to discuss with you something. Okay, so I want to discuss with you about the association between your hyperprolactinemia and galactorrhea. Okay, hyperprolactinemia is high levels of prolactin. Galactorrhea is secretion of milk. Okay, that is milk secretion is present. Okay, now, so let's see hyperprolactinemia. Hyperprolactinemia and galactorrhea. Okay. Remember, in patients who are having hyperprolactinemia, 50% of them will be going to present with galactorrhea. Only 50% of. The same way, in people who are having galactorrhea, 50% will be having normal prolactin. Yes? You understood this concept? Okay. So this association between galactorrhea and hyperprolactinemia is going to be called together as a syndrome called hyperprolactinemia amenorrhea syndrome. Okay. Now, let's discuss what is hyperprolactinemia without galactorrhea. So, hyperprolactinemia without galactorrhea. Okay. So, that means prolactin levels are more, and it is mostly due to the biologically inactive form of prolactin, that is macroprolactin. Okay. So only macroprolactin is more. It is biologically inactive. So that is not causing galactorrhea. Understood? But if you measure in these patients, what it will be showing? It will be showing a high levels of prolactin. Clear? Yes. And the next condition is galactorrhea without prolactinemia. So how this can happen? So this can happen with the effect called hook effect. Okay, so there is an effect called hook effect. So here the high levels of prolactin is not shown. Okay, there is high levels of prolactin, but in the test it is not shown because of a prozone phenomenon. Okay, so in this case, if there is any disparity like this, galactorrhea is there but hyperprolactinemia is not there, means you have to suspect prozone phenomenon and hook effect, and you have to measure it again with the diluted sample. Okay, and as I told you, the measurement should be done in the early morning. Clear? Now let's discuss about the management of hyperprolactinemia. Okay, we have microadenoma. So microadenoma can be treated with drugs. Okay, what is the drug we use? Yes, bromocriptine. So it is bromocriptine that can be given at a dose of 1.25 milligram per deciliter, that will be gradually increased up to 2 to 3 times daily. Okay, yes, you can also give cabergoline, and the dose will be 0.25 milligram once or twice a week. Okay, so this is how you will treat microadenoma. And whenever the patient is having a macroadenoma, okay, you have to see the size of the tumor, and whenever it is more than 3 centimeter, you have to directly offer them surgery, and the surgery what you will offer them is a transsphenoidal adenectomy. Okay, suppose in case of there is any intolerance or resistance to dopamine agonist, you can give the surgery. Okay, you can offer the surgery as well in microadenoma. Clear? And finally, suppose if it is surgically non-resectable or if it is persistent even after surgical removal, then you can even offer them radiation. So radiation is also another option. Clear? Yes. Now, let's discuss about thyroid disorders. How thyroid disorders are causing amenorrhea. Okay, so thyroid disorders. Okay, and as I already told, whenever you use the word amenorrhea and you have to use a thyroid disorder with it, it's more relatable to use hypothyroidism more than hyperthyroidism. Okay, because hyperthyroidism is going to cause menstrual abnormality, but it is going to be menorrhagia, not a amenorrhea. Clear? Right. Now, let's discuss this. So, how thyroid hormones are going to cause amenorrhea? Okay. See here, whenever there is reduced thyroid hormones, your TSH is going to be elevated. That is hypothyroidism. Okay. So when TSH is going to be elevated and TRH is going to be elevated. Okay, both of things are going to be elevated. So that is going to cause increase in prolactin levels also. So that is why there is an association between hypothyroidism and hyperprolactinemia. That's why they get galactorrhea in some cases of hypothyroidism. Okay, so that will prolactin will increase, but remember the prolactin levels will lie less than 100 milligram per milliliter. Okay, and that is going to increase the dopamine. Okay, because prolactin's enemy is dopamine. Yes, when prolactin is increasing, dopamine is also trying to increase its strength. Okay, so that will inhibit the GnRH secretion, gonadotropin releasing hormone secretion. So there is a decreased level of gonadotropins, and with the decreased level of gonadotropins, folliculogenesis is affected, and finally it will be resulting in an ovulation or amenorrhea. Clear? So this is how hypothyroidism is going to result in amenorrhea. Okay, yes. Now, so how will be treating this disorder? Simple. Yes, if you manage hypothyroidism, amenorrhea is going to be corrected, right? Yes. Okay. Now, I want to discuss about another important condition, that is primary ovarian failure. Okay, primary ovarian failure. See, normally menopause in Indian women happens around the age of 47 years, and in Western women it is around 51 years. Okay, in some people, okay, there can be ovarian failure which can occur less than 40 years also, okay. So that is known as primary ovarian failure, and due to this case they will have an early onset of menses, okay. So this can happen in less than 40 years age group in 1 in 100 women, and it can even happen in less than 30 years also, that is 1 in 3000 women, okay. And remember, 1 to 5% of the women experience this premature ovarian insufficiency or failure. Clear? Now, when this is happening, what will be the hormonal parameters you will be having? Yes, you will have amenorrhea, definitely. There is estrogen deficiency in this woman. Yes. So because of this, there is very important point is there is elevated levels of FSH, okay, before 40 years itself. Okay. So what are the causes? Okay, what are the causes of this premature ovarian failure? The causes may be idiopathic, or it can be due to some of the autoimmune disorders, maybe due to some of the chromosomal conditions, as well as genetic conditions as well. Okay, so let's see how we are going to diagnose this condition. Okay, so diagnosis, we can do diagnosis by measuring FSH levels. When FSH levels are more than 30 to 40 milli-units per milliliter, okay, milli-international units per milliliter, you have to confirm this increased FSH in 2 samples, okay, taken 1 month apart. 1 month apart, then only you have to confirm the condition, okay. So that is one way of diagnosing this condition. You can offer them karyotyping. You can you can ask them for the family history of autoimmune disorders. Then you have to test specifically for one gene, that is your FMR1 gene. Okay, so this gene is nothing but fragile X mental retardation 1 gene. Okay, so this is usually associated with premature ovarian insufficiency, and in females for having this chromosomal abnormality, the offspring can also have a fragile X syndrome. Okay, so this has to be checked. And remember, as soon as the woman presents with the primary ovarian failure, a ovarian biopsy, which is a very invasive procedure, is not recommended at all. Okay, so don't offer ovarian biopsy in these patients. Clear? Right. Now, so how will you manage this condition? So management, you have to give them estrogen and progesterone combination to maintain their secondary sexual characters, okay, as well as one important complication with menopause, early menopause or early menopauses, osteoporosis. We have to prevent osteoporosis as well. Okay, you have to advise them to take weight bearing exercises. Okay, then you have to give them supplements. Okay, supplements like calcium, which can be given at a dose of 1200 milligram per day, and then vitamin D3, which can be given at a dose of 800 international units daily. Clear? So these are the supplements you can give them. And in some cases, rarely, okay, what happens, even after this insufficiency or failure or secondary amenorrhea due to ovarian cause has set in, spontaneous ovulation can occur, and that can result in conception. Okay, rare, very rare, but this can happen. Keep that in mind. Okay, and then suppose if fertility is decide in these women, okay, when the ovaries had undergone failure, say at 30 years she is desire of a pregnancy, then you can offer them donor eggs. Okay, so this is how you can manage premature ovarian insufficiency. Clear? Now let's talk about one of the interesting syndrome in secondary amenorrhea. Okay, Sheehan syndrome. Okay, Sheehan's syndrome. See, Sheehan syndrome, simply in one line I have to define the syndrome, means I can tell it as a postpartum pituitary necrosis. Okay, so there is necrosis of cells where in the anterior pituitary gland. Okay, necrosis of the cells in anterior pituitary gland. Clear? And then what are the causes that can cause Sheehan syndrome? Okay, the causes will include postpartum hemorrhage, hypovolemia, and then shock. Okay, now you can ask me, ma'am, how a postpartum hemorrhage, hypovolemia, shock is all with the fluid balance, then how it is going to cause Sheehan syndrome and how it is going to cause amenorrhea or menstrual abnormality? Yes, it is going to, let me explain that, the pathophysiology of Sheehan syndrome. Okay, see, you have to understand that during pregnancy, what happens means there is increase in the pituitary volume. Okay, pituitary volume is going to increase. Okay, and the cell count is also going to increase, especially due to hyperplasia. Okay, this is all happening in the pituitary. Okay, so when the cell size and pituitary size is increasing, obviously there is increased nutritional and metabolic demand by the anterior pituitary gland, right? By the anterior pituitary gland mainly. Okay, it is especially the anterior pituitary you have to consider. Okay, because the blood supply does not increase here, and the blood supply received in anterior pituitary is a low pressure system. Okay, so anterior pituitary is going to get affected when there is a PPH or hypovolemia or shock. The size of the pituitary is increasing, but the blood supply is not increasing, and the minimal blood supply, whatever it is getting to the enlarged gland also, is not coming when a PPH or hypovolemia or a shock happens. Clear? Now, so this makes the pituitary more susceptible to ischemia, especially the anterior pituitary. Okay, and then if you take the posterior pituitary, the blood supply is from a high pressure system. Okay, so in most of the times the posterior pituitary function is not affected. Clear? So how they will be presenting, okay, in Sheehan syndrome? So presentation is going to be pan hypopituitarism, okay, and then prolactin and growth hormones, or the hormones which are most commonly affected. Okay, most commonly affected. As I told, posterior pituitary function is not going to get affected, and sometimes, okay, sometimes it can also present as a chronic condition. Okay, and remember, presenting as a chronic condition is more common when compared to acute condition. Okay, Sheehan syndrome presenting as a chronic one is more common when compared to acute condition. Okay. So now let's see what are the clinical features we have when Sheehan syndrome is presenting as a acute or a chronic condition. Okay. So acute condition means the features will include agalactorrhea, amenorrhea, then there can be hypotension or tachycardia, or else hyponatremia and even hypoglycemia. Okay, so soon after delivery, okay, you sent the female after delivery, she had a PPH, you sent to the women, she is lactating in your institute, whatever, and you sent her to home. Within 1 week or 10 days, she is returning to you that there is no secretions, her bleeding has stopped, and she is very feeling giddiness, okay, because of hypotension. And when you see her sugars, it is hypoglycemia and tachycardia, you have to soon suspect Sheehan syndrome. Clear? Yes. Now, and it can happen even after years, okay, even after years she had a delivery, she had a PPH, okay. So that is chronic Sheehan syndrome. They can present with features like hypothyroidism, fatigue, weakness, hair loss, constipation, then weight gain, cold intolerance, hypotension, bradycardia. Here they will have bradycardia, and most of the symptoms of hypothyroidism will be present here. Okay, and obviously they will have hypoglycemia and hyponatremia. Okay, when suddenly a woman is presenting with these features in your OPD, you can even ask her for the history if she had a PPH during any of her delivery. Okay, so that will be bringing to your diagnosis of chronic Sheehan syndrome. Clear? Yes. Now, investigations. There will be reduced levels of LH and FSH, reduced levels of growth hormones, decreased ACTH, adrenocorticotropic hormone. Then there is decreased level of prolactin and decreased level of TSH as well. Okay, you have to check for the electrolytes as well as sugars, which will be showing hyponatremia and hypoglycemia as well. Clear? Now, other investigation you can offer them is MRI to confirm diagnosis. If you take MRI, 70% of the cases of the women with Sheehan syndrome, because there's a pituitary necrosis, right? So 70% of them will be showing empty cella, whereas in 30% of the cases, there is a partial empty cella as well. Okay, so how you will be managing these cases? So management, mainly you have to supplement, yes, levothyroxine, because there are more of hypothyroidism features. Levothyroxine, you have to supplement them, and if there is gonadotropin deficiency, you have to treat that also. Okay, and whenever there is gonadotropin deficiency, what I would advise is you shouldn't supplement any hormone just like that. Okay, whenever you have gonadotropin deficiency, you have to check whether the uterus is present or not. Okay, uterus is present or not. When the uterus is present, you can offer them estrogen. Okay, when the uterus is absent, you can offer them estrogen and progesterone. Both can be offered. Clear? Yes? I know this is exhausting, the topic of amenorrhea, but still we are about to end it. Okay, so for the last few minutes, I hope you will be concentrating. So this is another beautiful and interesting syndrome, Asherman syndrome. So you have In this syndrome, you have intrauterine adhesions or intrauterine synechiae. Okay, so you have scar that is formed in the uterus or cervix or in both. Okay, so what are the causes? Causes will include dilatation and curettage, and then sampling for endometrial cancer. When you do removal of endometrial polyps, and if there is a hysteroscopic resection done for any septum or fibroid, whatever. Okay, so what is the pathophysiology in Asherman syndromes means? There is damage, okay, to the basal layer of endometrium. Okay, so this is going to trigger an inflammatory process, and this is going to cause adhesions. Okay, so there are adhesions that is extending from one side of the cavity to the other in the form of bands. Okay, and remember, in these cases of Asherman syndrome, most of them present with infertility. Okay, but menstrual irregularities as a group will be constituting the most important cause of presentation in Asherman syndrome. Okay, so that will include what they may present as amenorrhea, hypomenorrhea, or dysmenorrhea as well. Clear? Right? So what are the investigations you will offer them in this case? You can offer them 2D ultrasonogram, which will be the initial investigation of choice in these patients, and you can offer them saline infusion sonography or hysterosalpingography. Okay, so in hysterosalpingography, the picture will be like this. Okay, you will be able to see small multiple irregular filling defects. I hope you are able to see here. Okay, so there are small multiple irregular filling defects, okay, which will suggest Asherman syndrome. And another investigation which you can offer is hysteroscopy. Okay, so this is a hysteroscopic picture of Asherman syndrome, okay, where you are able to see adhesions that is present between the both walls of the uterus. Okay, so what happens is the ostia as well as the fundus of the uterus are drawn. Okay, so there will be dimping of the fundus, and the ostia is also going to come down like this. Okay, whereas in a normal uterus, the position will be like this. Okay, it will be a straight one, but because there are so much will be adhesions present here, so there is dimping above the fundus. Okay, so this will be seen in hysteroscopy. Okay, and remember, you can also go for an MRI investigation when there is a total obliteration of the endometrial cavity where you couldn't do a hysteroscope. Okay, and finally, hysteroscope is not only a method of investigation, but it can also be used as a treatment modality to do adhesolysis. Okay, we can even give adhesolysis through hysteroscopy. Okay, now before ending this, I want to talk about the AFS classification of Asherman syndrome, where it is divided into mild, moderate, and severe. Okay, so mild features will have, mild Asherman syndrome means there are only filmy adhesions, that is less than 1/3 of the cavity, 1/3 of cavity, and they will be presenting mostly with hypomenorrhea. Okay, whereas in moderate Asherman syndrome, there are filmy adhesions, but in some regions you will also see dense adhesions as well, and this can extend anywhere between 1/3 of the cavity to 2/3 of the cavity, and they can present with hypomenorrhea as well. Okay, and in severe Asherman syndrome, there can be only dense adhesions which is involving more than 2/3 of the cavity, and these patients will be presenting with amenorrhea. Clear? So this is Asherman syndrome that is given according to the AFS Society, that is American Fertility Society classification of Asherman's syndrome. Right? Now, management of Asherman syndrome, as I previously told you, you can go for a hysteroscopic adhesolysis. Okay, hysteroscopic adhesolysis can be offered, and then preoperative and post-operative treatment with estrogens may be helpful. So when you supplement them with estrogens, it will reduce the scarring. Okay, scarring can be reduced post-operatively if any procedure is undertaken involving the uterus, and sometimes adhesive gel. Okay, adhesive gel that is containing hyaluronidase can also be given. And finally, every time you do a procedure, you have to reevaluate the patient, okay, after 2 to 3 weeks after a procedure. Clear? Okay, fine. Now, let's talk about post-pill amenorrhea as a cause of secondary amenorrhea, because many women who take pills, okay, they will come with this complaint. Post-pill amenorrhea. They took the pills and suddenly their cycles have stopped. Okay, this will be the complaint they will be coming. So let's see why this is happening. See, after stopping OCPs, okay, if they take, it will take some few months for the normal return of the cycles after they have stopped it. Okay, so post-pill amenorrhea is seen in 0.7 to 0.8% of the cases. However, if amenorrhea is persisting more than 6 months, then you have to rule out other causes of secondary amenorrhea as well. Okay, rule out other causes of secondary amenorrhea as well. Clear? Right. Now, next one is functional hypothalamic amenorrhea. So what's happening here is, due to any functional activity, say there is emotional stress, okay, or she does a vigorous exercise, okay, as in a case of athlete, then she is under any chronic illness, okay, there is any chronic illness in her, or there is a plan to do weight loss suddenly. Okay, in all these cases, what happens means GnRH levels will reduce. That is going to reduce their luteinizing hormone levels, and there will be absence of your mid-cycle surge and ovulation. Okay, and in these cases, FSH levels are going to remain low or normal. Okay, so this is how functional hypothalamic amenorrhea is going to happen. And we have a triad here, that is female athletic triad, which will include the features like menstrual dysfunction, fatigue, or low bone mineral density. Okay, so what are the investigations you offer for this patient? investigations you offer include urine pregnancy test. Don't forget this test in any case of amenorrhea. Then thyroid function test, as well as you have to assess her estrogen status. Okay, assess her estrogen status as well. Okay, so if serum estradiol levels is more than 40 picogram per milliliter, means then it will suggest functioning ovarian follicles. Okay, that means there are functioning ovarian follicles. And what you can do is, you can offer them a progesterone challenge test. Okay, you can offer them a progesterone challenge test. Okay, where you can give the drug medroxyprogesterone acetate 10 milligram orally for 7 to 10 days. Okay, and mostly when you give this drug, you will be anticipating withdrawal bleeding, right? So when you expect withdrawal bleeding in these patients, and if the withdrawal bleeding is happening or not happening, okay, so if it is happening, means you're sure that you have normal estrogen levels, normal endometrium, and you have a very important point, yes, patent outflow tract as well. Clear? And when the withdrawal bleeding is not happening, then it means there can be chances of hypogonadism, or there can be a defect in outflow tract. Clear? And remember one more point. Okay, not only by giving a progesterone challenge test, you can test the endometrium by using an ultrasonogram also, right? So for that, you can measure ET, the ET thickness by TVS. Okay, you do your TVS, that is the most non-invasive, most acceptable method of ultrasonogram to measure endometrial thickness. And if the ET anytime goes above 6 millimeter, then it can say that withdrawal bleeding is possible with 95% accuracy. Okay, then you can also offer them USG pelvis to rule out PCOS or androgen secreting tumor, and CT and MRI can also be done in them to rule out any tumor, disease, or disease of the brain or pituitary. Clear? Yes. Next one is, yeah, offer them a chromosomal analysis as well. And remember, tuberculosis has also to be ruled out in them. Clear? Yes. I hope we have come to the end of our presentation, and let's finalize the algorithm to diagnose secondary amenorrhea. Okay, so yeah, so this is the algorithm to diagnose secondary amenorrhea. So first you will be going with the history taking examination, and you have to rule out any intake of medicine, or definitely you have to exclude the pregnancy as well. And after that, you have to offer them investigations like thyroid stimulating hormone, prolactin, and follicle stimulating hormone, luteinizing hormone. You have to offer them pelvic ultrasonography also. And then you have to assess the estrogen status, especially the estrogen E2, then progesterone challenge test has to be given. Okay, you have to measure for the endometrial thickness as well. So when there is normal E2 levels, withdrawal bleeding is positive, and ET is more than 6 millimeter, means then it is chronic anovulation. Okay, suppose E2 is low, withdrawal bleeding is negative, and ET is also less, means you have to give them a estrogen progesterone challenge test. Okay, estrogen progesterone challenge test. It is not progesterone challenge test or not. Here we are giving estrogen also. Okay, when you give estrogen progesterone challenge test and still it is coming as negative, then you have to suspect Asherman syndrome and you have to offer them a hysteroscopic procedure to diagnose as well as treat the procedure in one setting. Okay, suppose if the estrogen progesterone challenge test is coming as positive one, then you have to check for the FSH levels. If the FSH are high, it is going to be ovarian failure or Kallmann syndrome, which is having FMRN mutation in a premature ovarian insufficiency or other autoimmune conditions also. Okay, and suppose if the FSH is low, okay, offer them MRI brain. In MRI brain, you will be able to rule out whether it is a pituitary adenoma or a hypothalamic amenorrhea. Okay, and suppose if there is a abnormal TSH, then you will be knowing it is a thyroid disorder, and if it is a hyperprolactinemia, you can give them MRI of brain if indicated. Okay, so this is all about secondary amenorrhea. Yes, with this we are coming to the end of the session. I hope you enjoyed the session, and I have I have given amenorrhea in a much simple way. I have summarized it. So hope this will be helpful. Until we meet in the next session, take care, happy learning, and bye bye.